Our first topic, our talk is PET-CT in head and neck malignancies, to be given by Dr. Maseeh Zaman. He is a consultant nuclear medicine physician for the last 2 decades. He has been awarded fellowship from College of Physicians and Surgeons, Pakistan, having European Board in Nuclear Medicine, American Society of Nuclear Cardiology. He is affiliated with Aga Khan University Hospital as a professor and section head of Nuclear Medicine Radiology Department. His basic area of research interests are nuclear cardiology, PET oncology, and therapeutic nuclear medicine. He has about 150 publications in his account and has contributed chapters in 2 books. He is also an editor of Pakistan Journal of Radiology and member of editorial reviewers team of other peer-reviewed journals as well. In recognition of his academic and research contributions, Royal College of Physicians, Edinburgh, has conferred him status of a fellow. Sir, please.
Thank you, Dr. Saima, and I'm extremely grateful to Professor Shazia and the whole team of the Pakistan Society of Nuclear Medicine and the wonderful audience for their presence and attention. I've been giving the topic of role of FDG PET-CT in squamous cell carcinoma of head and neck. And regarding this presentation, I have no conflict of interest. And in the next 20 minutes, we'll be talking about how the FDG PET-CT should be performed in an standardized imaging protocol. And then we'll go through its role in staging carcinoma of unknown primary response assessment, radiation planning, follow-up, and in patients with surveillance and suspected recurrence. As we know that the head and neck cancer is the 7th most common cancer throughout the world, and 90% of the cancers are the squamous cell carcinoma, while the 10% of the population, they do have the lymphoma, thyroid, and salivary glands. The overall survival of the head and neck cancer is about 63%, which reduced to 50% with the presence of the nodal metastasis, even with the occult one. Therefore, precise staging is paramount, and in this regard, morphological and metabolic imaging plays an important role. Morphological imaging like the contrast-enhanced CT and MRI plays an important role in T staging because of their higher spatial resolution. MRI, because of its higher soft tissue contrast, plays an important role in nasopharyngeal, oropharyngeal, and oral cavity cancers and considered as a modality of choice for the diagnosis of the perineural extension, marrow and mandibular invasion, and also for the brain metastasis, where the FDG has a limited sensitivity. Similarly, the contrast-enhanced CT plays an important role in the T staging of the laryngeal cancers and also to get the answers about the bone cortical invasion and also for the smaller lung metastasis where the FDG PET-CT has limited sensitivity due to the partial volume effect. Now come to the hybrid imaging modality, and the most commonly one is fluorodeoxyglucose labeled PET-CT. It is importantly considered for the nodal and the distant metastasis except for the brain and the lung, and also considered as a modality of choice for the diagnosis of the primary tumor in patients with carcinoma of unknown primary having squamous cell metastatic nodal disease. The second primary malignancy during the workup of these patients is not uncommonly seen on patients with FDG PET-CT, and it is considered modality of the first choice for therapeutic response assessment and also for the radiation planning and in suspected recurrence. Just to give you briefly how the standardized imaging protocol should be performed, especially for sequential FDG PET-CT, after at least 6 hours fasting, when the fasting blood glucose level is less than 200, we inject fluorodeoxyglucose in a dose of the 3 to 5 megabecquerel per kg and at least 60 minutes with the range of the 55 to 70 for the sequential studies. The PET-CT images are required by sending the patient to the PET-CT scanner, where from midbrain to the mid-thigh, CT PET images are required sequentially, and then we have the 2 sets of the images for evaluation, both for the qualitative and semi-quantitative by drawing the region of interest over hypermetabolic primary and metastatic nodal disease for assessment of the standardized uptake values. The higher diagnostic accuracy of FDG for detection of the primary tumor is unmatchable. It is more than 96%, but because of its limited resolution, and it is unable to give the clear distinction or clear demarcation with the neighboring structure. Therefore, the false negative findings are not uncommon if we use it for the T staging, where the T1 tumor especially, and also the tumors in the pharyngeal lymphoid tissue where there is physiological increase uptake is there. Similarly, false positive findings because of the areas of the high physiological uptake and inflammatory process, as we know that the FDG is a non-specific imaging substrate. But when the question of the dental artifact with mandibular invasion, then FDG PET-CT outperforms by its diagnostic accuracy, contrast, and NCT. This is an example of hypermetabolic lymph node in right upper cervical region being denoted as a yellow marker, and there is a uniform tracer uptake. But when we see that the histopathology, there was a small sub-centimeter squamous cell carcinoma lesion in the right tonsillar area. The nodal involvement is considered as one of the most important prognostic factor, and once it is there, the disease is outrightly stage 2, stage 3. And it predicts the further nodal recurrence and the distant metastasis, and also the survival reduced by 50% in patients with positive nodes. FDG PET-CT again outperforms contrast, NCT, and MRI more than 85% diagnostic accuracy. This is an example of hypermetabolic primary tumor in right supraglottic region with hypermetabolic concomitant lymph nodes on right side of the neck, both in CT and MRI, but CT and PET. But the PET is showing an additional hypermetabolic lymph node on left side, being indicated as a white marker, which was turned out to be a metastatic lymph node. So an additional lymph node was found, and the disease stage was changed. Similarly, in patients where the FDG PET-CT in clinically negative neck is there, it is an important question to answer. In this regard, American College of Radiology, they conducted a multi-central trial, that is the ECRIN 6685 trial, and in this trial they have included 23 American College of Radiology institutions and 212 patients. They were recruited having a disease of the T2, T4, and C and not. And all these patients, they underwent FDG PET-CT and neck dissection. And interestingly, the negative predictive value of the visual analysis was 87%, which increased to 94% with SUV max cutoff more than 1.8. And in ECRIN 6685, the surgical decision was changed by FDG PET-CT in about 22% of the participant. Distant metastasis at the time of the presentation in head and neck cancer is uncommon. It is seen in about 2 to 18% of patients, but once it is there, it is an indicator of poor prognosis, and radical treatment is usually avoided. The common sites of distant metastasis are lung, liver, and bone, and these are the predictors of the locally advanced disease and also for the recurrence. PET metabolic imaging predictors for the distant metastasis are the high SUV max, total lesion glycolysis, and metabolic tumor volume. And in this regard, the various studies have shown that the MTV and the TLG are the independent risk factors for progressive disease and overall survival. Similarly, the certain biological markers, they are considered to have to favor a favorable outcome if there is Epstein-Barr virus positive serology, and similarly the positive serology for human papilloma virus in patients with oropharyngeal cancer. The National Cancer Comprehensive Network Guidelines recommends use of the FDG PET-CT for advanced nodal disease and also for the distant metastasis. Like in this patient, we can see that there is hypermetabolic nodal disease in bilateral neck with a hypermetabolic primary focus in the left side of the nasopharynx indicated by the narrow yellow marker. But in addition, there is a small well-defined hypermetabolic marrow deposit denoted by the wider or the broader yellow arrow in the T7 vertebrae. Therefore, the disease was stage 2, stage 4. Another case of hypermetabolic right tonsillar SCC with bilateral hypermetabolic lymph node, and there's a small hypermetabolic and hypodense lesion in segment 6 of the liver, which was turned out to be metastatic at the time of the staging. Therefore, this disease was stage 2, stage 4. The second primary tumor is not uncommon during the clinical work of these head and neck patients. It is seen in about 5 to 10% of patients, and these tumors could be metachronous or synchronous, and the most common sites are head and neck, thorax, esophagus, and lung, and most commonly it is seen in smokers and also in patients with negative human papilloma serology. Like in this patient, we can see that there is a red marker which is showing a hypermetabolic focus in thoracic esophagus, which is considered to be the CA esophagus in a patient with right piriform fossa tumor. Therefore, this patient was having a synchronous tumor, one in the head and neck and other in the mid esophagus, both of the squamous cell carcinoma. The metastatic squamous cell carcinoma on cervical nodal disease without primary is an important entity which is seen in about 5 to 10% of the cases, and in such patients usually no primary tumor is found on clinical examination, pen endoscopy or cross-sectional examination. Therefore, American Society of the Clinical Oncology Guidelines published in 2020, it recommends use of the FDG PET-CT for diagnosis of the primary tumor in cup. And according to one meta-analysis which was published in 2021, the pooled diagnostic accuracy or the detection rate for the primary tumor was 40%, with a false positive finding of the 9%. And the common sites, both for the false positive and false negative, are palatine tonsils and base of the tongue. Like in this patient, we see a hypermetabolic metastatic lymph node in right upper cervical region. There is uniform thickening over the nasopharynx, but FDG shows there's a hypermetabolic uptake over the nasopharynx, which was considered as the primary site of the metastatic squamous cell carcinoma. Therapy response accurate assessment after the completion of the chemoradiation therapy is utmost important, and the morphological imaging plays limited role because of the treatment-induced hyperemia and loss of the fat plane. Furthermore, because of the introduction of the cytoreductive agents, the decrease or the diminution in the size of the primary and the metastatic nodes or the sites are progressive or gradually appears in 6 weeks to 6 months time. Therefore, the early metabolic response assessment is usually cumbersome. Therefore, in this regard, NCCN guidelines, which was published in 2023-2024, it recommends use of FDG PET-CT for precise metabolic response assessment 3 months after the completion of the chemoradiation therapy. And interestingly, large body of data shows that the negative predictive value of a negative FDG PET-CT 3 months after CRT is about 94 to 97%, which reaches to 99% at the time of the 1 year after the CRT. The positive predictive value of a positive scan is about 75%, most likely due to the false positive FDG uptake in the area of the treatment without compromising the overall survival and disease-free survival. As a general consensus between the nuclear physician and the radiologists who are reporting the FDG PET-CT, the mild diffuse FDG uptake is usually considered as post-intervention inflammatory response, while the intense and focal FDG uptake is considered likely residual disease. However, in this regard, various professional societies, they have issued certain reporting criteria, and one of the most common one is the Hopkins 5-point scoring, which was developed from the dual 5-point scoring from the lymphoma one. And in this regard, the reference uptake is used as internal jugular vein and the liver, where it is compared with the primary tumor and the metastatic lymph node. The score one is when the focal uptake is less than internal jugular vein, and in this regard it is considered as a complete metabolic response, while the score 5, where there is an intense uptake more than liver, it is considered as residual or recurrent disease. American College of Radiology, they have also published or released another reporting system, that is the NIRAD system, neck imaging reporting and data reporting system. But the limitation of this NIRAD reporting system is that it do not mention any reference standard for FDG uptake of the primary and the metastatic nodal site. Therefore, there is significant inter-observer reproducibility. As a result, most of the nuclear medicine lab, they do not use the NIDAD reporting system. But as we know that most of our nuclear medicine physicians, we use the semi-quantitative parameters like the SUV max, metabolic tumor volume, and TLG, and with the general consensus that if there is more than 30% reduction from the baseline, it is considered as a partial metabolic response, and if there is 20% increase from the baseline or with the appearance of a new lesion, it is considered as progressive disease. But at this point, it is important to reiterate that the accuracy of the metabolic response assessment totally depends upon the standardization of the imaging and reporting protocol, as has been strongly stressed by the European Association of Nuclear Medicine Guidelines, which was published in 2015, because these metabolic parameters, they depend on various confounding factors, right from the fasting blood glucose level between the baseline and the follow-up scan, and the calibration of the PET-CT scan at the baseline and the follow-up scan. Therefore, being the nuclear medicine fraternity, it is our responsibility to be very cautious about the standardization of these parameters to get a meaningful and precise metabolic response assessment, which is very important. This is an example where the hypermetabolic primary and metastatic lymph node, they get normalized or absent 3 months after the CRT, that is the CMR. There is an incomplete reduction. Therefore, this is consistent with partial metabolic response after the chemotherapy. And in this case, there is significant reduction after the 6th chemotherapy, but the uptake of the residual node is more than internal jugular vein. And after 5 months of post-chemotherapy, there is recurrence of the increased metabolic activity over these nodes, which was consistent with metabolically active recurrence of the disease. The post-CRT negative FDG PET-CT is a very good news for the treating physician, because it essentially rules out the viable disease, and therefore in such cases no neck dissection is required. And according to one study in which the nodes were enlarged, they were necrotic but without abnormal metabolic FDG activity, it was found that it essentially excluded the viable tumor with a specificity of 89% and a negative predictive value of 97%. And in these patients, no neck dissection was performed without compromising or impairing the overall survival. FDG PET-CT in last decade has become a very good neighbor and friend of radiation oncologists, because it helps them in selecting the patient, whether it is locally or the advanced metastatic disease. The patient should be treated curatively or palliatively, and by using the FDG PET-CT, they can delineate the gross tumor volume. Similarly, by the dose penting technique, they can increase the dose to the hypoxic or hypermetabolic tumor subvolume, and in the adoptive radiotherapy, the radiation oncologist can always enhance or de-escalate the radiation dose during the treatment therapy. This is an example of the radiation planning by using the contrast NNCT and FDG PET-CT, and we can see that the radiation planning area is significantly smaller on PET-CT as compared to the contrast NNCT. Therefore, it reduces the unjustified radiation exposure to the peritumoral normal tissue. The cost-effective analysis is again an important thing, because the negative FDG PET-CT, as we know that it rules out disease 3 months after the CRT, but initial days, the various clinical trials, randomized clinical trials were performed by doing the neck dissection in these patients. And one of the most common and most popular trial was a PET neck trial, which was conducted in United Kingdom in 2016, and it was published in New England and Journal of Medicine. The findings were that there was no significant difference in quality of life on those patients who had a negative FDG PET-CT and who did not undergo neck dissection. But the patients who did not undergo neck dissection with a negative FDG PET-CT, the cost saving was $2,200, which was significantly higher. So at this point, just to conclude that the FDG PET-CT is considered as an effective imaging modality in the management of the head and neck cancer. It is considered as standard of care for locally advanced disease, and based on the current evidence-based guidelines, it is considered as the most important imaging modality for the nodal and the distant metastasis for the detection of the primary tumor in carcinoma of unknown primary, a good friend in radiation planning, and it is considered the modality of choice for accurate assessment of treatment after the completion of the chemoradiation therapy. And finally, the high negative predictive value avoids the neck dissection with a significant or the huge cost of the saving of $2,200 US. And finally, just to reiterate that the standardized imaging protocol and imaging and the reporting protocol is the primary responsibility of the nuclear physician and the nuclear medicine laboratory. At this point, I would like to finish my talk, and once again, I'm extremely grateful to Dr. Shazia Fatma, my senior colleague, Dr. Khalid Nawaz, Dr. Amin Waqar, and all the audience. Thank you very much, ladies and gentlemen, for your kind patience and attention. Thank you.